Hello, I am Amy Donatov, Director of Coding Services for MSOC Health. The Medicare contractor for North Carolina, Palmetto GBA, continues to perform service-specific, prepayment, targeted medical review on Part B claims for surgical debridement services. The intent of this video is to provide you with a brief overview of Medicare's LCD policy related to wound debridement. This information is current as of 11/10/2014. The LCD applies to debridement of localized areas such as wounds and ulcers. It does not apply to the removal of extensive eczematous or infected skin. So let's take a look at the CPT codes applicable to this discussion. CPT codes 11042 through 11047. The AMA CPT definitions are presented here. Notice that each base code, 11042, 11043, and 11044, each have a corresponding add-on code if the measurement exceeds 20 square centimeters. If the debridement is not down to a subcutaneous tissue or is simply active wound care management, then you should not use 11042 through 11047 and use 97597. A debridement of a burn wound is coded in the section 16020 through 16030. You would not use 11042 through 11047 in conjunction with a 97597 through 975602 for the same wound. Now we will review the indications for wound debridement. Debridement is defined as the removal of foreign material or devitalized or contaminated tissue from or adjacent to a traumatic or infected wound until surrounding healthy tissue is exposed. It is indicated whenever necrotic tissue is present on an open wound and in cases of abnormal wound healing or repair. The techniques usually progress from non-selective to selective but can be combined. Selective debridement refers to the removal of specific targeted areas of devitalized or necrotic tissue from a wound along the margin of viable tissue. Occasional bleeding and pain may occur. The routine application of a topical or local anesthetic does not elevate active wound care management to surgical debridement. Selective debridement includes selective removal of necrotic tissue by sharp dissection, including scissors, scalpel, and forceps, and selective removal of necrotic tissue by high-pressure water jet. Selective debridement should only be done under the specific order of a physician. It will not be considered a reasonable and necessary procedure for a wound that is clean and free of necrotic tissue, and is used in the management and treatment of wounds or ulcers of the skin and underlying tissue. Providers should select a debridement method most appropriate to the type of wound, the amount of devitalized tissue, and the condition of the patient, the setting, and the provider's experience. Palmetto GBA does not consider the following services to be debridement: removal of necrotic tissue by cleansing, scraping, chemical application, and wet to dry dressing, washing bacterial or fungal debris from the lesion, removal of secretions and coagulation serum from normal skin surrounding an ulcer, dressing of small or superficial lesions, trimming of callous or fibrinous material from the margin of the ulcer, paring or cutting of corns or non-plantar calluses, or I&D of abscess. We will now review the documentation requirements for wound debridement. You must include the medical necessity for each date of service, the tool used for debridement, frequency of debridement, measurement of total devitalized tissue before and after the procedure, the area and depth of devitalized tissue removed, not just the depth, blood loss, and description of tissue removed. A detailed description of the procedure should be included. Evidence of progress of the wound's response to treatment to include at a minimum the current wound volume, the surface dimension and depth, the presence and extent of or absence of obvious signs of infection, the presence and extent of or absence of necrotic, devitalized, or non-viable tissue, and other material in the wound that is expected to inhibit healing or promote adjacent tissue breakdown. Services performed for excessive frequency, debridement more than one time a week, or more than 8 times for a chronic ulcer are not medically necessary. Services performed more frequently than generally accepted by peers must include a complete description of the wound, progress towards healing, complications that have delayed the healing, and a projected number of additional treatments necessary. As I mentioned at the beginning of this video, Medicare performs prepayment reviews for wound debridement services. The focus is CPT Codes 11042 through 11047, provided in outpatient settings or places of service 22. The results for the review period April 1, 2014 through June 30, 2014 show a total of 1,994 claims lines that were reviewed, with 637 either completely or partially denied. The total charges reviewed were 147,258, out of which 45,821 were denied, resulting in a charge denial rate of 31.1%. The top denial categories identified based on dollars denied are listed below. As you see, 45% of the time, no or partial documentation is received. 37% of the time, Palmetto GBA determines that the documentation does not support medical necessity. And 5% of the time, no documentation, the signature was not included on the documentation. We'll review the specific findings for not medically necessary. There was no documentation of a post-wound debridement size and depth noted. Pre-debridement wound volume was not noted. The presence with extent of or absence of obvious signs or infection were not noted. The presence with extent of or absence of necrotic, devitalized, or non-viable tissue was not noted. Level of tissue removed to support the CPT code bill was not provided. No surgical debridement was noted, and the presence of foreign or other material in the wound was not noted. Any complicating factors for the prolonged debridement was not included. I hope this webinar provides you with helpful information to ensure proper documentation for wound debridement. Please contact me or your client analyst if you have any questions.